Welcome to the Infection Prevention Strategy Tips Masterclass, Breakthrough in the Contagiousness Paradox, the myth of 98.6 and 100.4 Fahrenheit. Thank you for joining this informative webinar. This masterclass presents a breakthrough in employee health and safety, introducing a new technology, protocols, and processes into how we determine contagiousness in the workplace. This paradigm shift in thinking emphasizes body temperature as the earliest indicator of contagiousness rather than a late indicator, and how a person's known body temperature can be near perfect indicator of contagiousness. The learning objectives for today are posted on your screen for your convenience. My name is Dan Mueller. I'm Senior Vice President with Corsia Healthcare and a TIPS Advisory Board member. This presentation will last 50 minutes, followed by a Q&A session. If you have any questions, please type your questions into the Q&A panel. All your microphones have been muted. This webinar series is hosted by TIPS. TIPS is a not-for-profit that exists to advance innovations, ideas, and processes that make a difference in global health. TIPS extends to over 30 countries and is the key strategic partner for many notable organizations, initiatives, and events. In the past few years, TIPS has contributed millions in scientific impact. This is our mission statement. Our motto is join, contribute, make a difference. And we also have a disclaimer statement. Please contact your local regional health authorities for specific instruction on all topics mentioned in this webinar. The webinar is sponsored today by Wello. Wello's primary focus over the past decade has been minimizing the spread of contagious disease. With over 1,500 automated FCC Class II thermometer stations deployed and more than 15 million scans conducted, Wello has amassed a wealth of data. A subset of this data was used to validate a new wellness protocol to enhance the accuracy using AI and biostatistical decision tools with PCR validation. While other tools can perform this protocol, Wello's device stands out as the only automated FCC Class II thermometer. It is manufactured in the US as well as FDA-audited facility. A comprehensive analysis drawing insights from senior residencies, hospitals, offices, and manufacturing sectors employing fever scanning has been undertaken to accurately the identification of potentially contagious employees. This study leveraged the expertise of published epidemiologists, biostatisticians, and other professionals to gather and validate findings, possibly heralding a new groundbreaking advancement in contagious employee detection. By integrating this discovery into a new wellness protocol requiring just 3 seconds per employee, health safety teams can efficiently deploy a decision-making tool to reduce unscheduled absenteeism rates. The upcoming presentation will explore the discovery process and its validation. For those nurses interested in a CE credit, you will earn 1 CE credit for attending this webinar. You will receive an email after the webinar from Terry Goodman, and she will walk you through the survey that will allow you to get that 1 CE credit. And if you have any questions, you can contact us at TIPS and we can assist. Introducing today's speaker. Our first speaker is Sherry Solomon, President of Clean Health Environmental. Clean Health provides infection prevention, industrial hygiene, and OSHA training and consulting services geared toward facility personnel and vendors responsible for infection prevention, cleaning, disinfection, and family operations and maintenance practices. Ms. Solomon possesses more than 20 years of environmental consulting and federal regulatory experience. An attorney by trade, combined with her experience in the industrial hygiene field with a focus on infection prevention, Sherry holds a unique expertise and understanding of liability prevention techniques, offering clients practical and valuable risk management. Ms. Solomon is a designated trainer under the Certified Healthcare Environmental Services Technician Program from the AHE of the American Hospital Association, as well as the Durable Coated Fabrics Task Force is affiliated with the American Academy of Healthcare Interior Designers. Sherry is a certified indoor environmental consultant through the ACAC and holds a Bachelor of Arts degree from the University of Florida and Juris Doctorate from the Catholic University of America. Our second speaker is Rick Heller, President, CEO of Wello. Since the 1990s, Rick has pioneered wireless sensing and machine learning, licensing groundbreaking IP to companies like Apple for AirTag and Tile. Campus-wide networks using these technologies are now commonplace in sectors like telecoms, semiconductor manufacturing, and hospitals, automated manual tasks associated with nurse call systems. Building upon the Wello Station X, the company recently developed and is announcing an AI protocol coupled with this fully automated FDA Class II thermometry medical device. Proven, this protocol identifies and grades symptomatic contagious employees from mere allergies-like sufferers. As well, it will also identify asymptomatic contagious individuals in seconds. This protocol advises non-disruptive methods of reducing by as much as 95% workplace contagion burden. With thousands of stations deployed, this new protocol can even promise a significant reduction in community spread diseases. And without further ado, Sherry will be presenting.
Thanks, Dan. Thanks again, Dan, and thank you all for having us here today. We're happy to be presenting on the breakthrough in the contagiousness paradox, the myth of 98.6 and 100.4. And we have clearly recognized, and based on Dan's introduction and my background, focused on infection prevention, we recognize that there is an increase in prevalence of infectious disease, poses significant challenges in workplace health management, and particularly the impact of presenteeism, absenteeism, and healthcare-associated infections. We know it has long been recognized that temperature is a key surveillance measure. However, there are significant limitations to this methodology and how we've been using it for the past number of years. And recognizing with new technology and new protocols, as well as data that we've been able to gather, we are able to refine that process and perhaps make surveillance even more robust. We know that presenteeism, which is defined as someone who comes to work when they know that they're sick or feeling ill symptoms, which creates absenteeism, is a significant impact on our workplace, both to our health of our workers, to the financial burden, and the cost to our employers. So what we want to go over with you today is really just to first share the impact of these transmissions with you and understanding the financial and health impact of spreading infections in the workplace. Discussing the limitations of how we're conducting surveillance now, looking at how we are taking temperature and defining that improperly, and the high likelihood of false negatives that infect our workplace. In addition, we recognize that the lack of robust protocols to monitor these currently contagious employees is substantial lacking. And I think, unfortunately, this was only more and further realized during the COVID pandemic, where we saw significant transfers of infection due to employers coming into workplaces sick, especially in our nursing homes and in our healthcare facilities. Once we go through sort of the problem and the challenge that we've been faced, I'll then pass it off to Rick Heller, who will then take the lead to share the solution on how the technology combined with the protocols can create a more robust surveillance program with limited impact on the worker or the workplace. And then Rick is going to dive into a case study that was conducted and the findings of that case study. And we'll finish up with understanding what protocols we can implement in place in order to ensure that we are minimizing that opportunity for transfer of infection in the workplace. So to get started and to sort of look at these normal temperature ranges of 3 employees, and this is really where we're going to start delving into the challenges. So we see here 3 examples, and denoting there the normal range is within the colored boxes, the extended range is above and below the box, and then the outlier is above their extended range. So just to get a feel for what you're looking at. So we recognize that people will have different baseline of temperature. So to get a better feel for how this really translates in the field, if we're looking at 4 employees, let's say that 2 feel well, 1 perhaps is coughing, and 1 is sneezing. So here are our 4 employees, and that's what they present themselves to be. But when we actually break it down and we see, based on the technology and based on the protocols we're using, while most people are well, some are contagious that look well and feel well. There's also allergies that come into play where someone may, if they're filling out a traditional surveillance form, a questionnaire, they may say they're sneezing, but is that actually due to an illness or due to allergies? And so the red shows the people that are coughing, sneezing, and likely it's allergies that are feeding in to some of those individuals. And so with the technology, we're allowed to parse through that, and we can actually define those folks that are in fact sick based on their baseline, or identify those that are false negatives, or perhaps determine those that are false positives and delineate that even further as we're going to get into. So it really allows us to introduce what the aspects of our workers are really versus what they're presenting themselves to be here. So what is the issue here, and what does this all come down to? And it really comes down to the challenges of presenteeism, which creates absenteeism. We know that when someone works sick and is contagious, there is an impact both on a health level and on a financial level. The Harvard Business Review estimates that presenteeism costs the economy approximately $150 billion a year. And again, this was only more obvious and clear during the pandemic. Presenteeism drives all workplace outbreaks, and staff are often asymptomatic, which why some are clear about presenting to work sick. So it may be the case that they feel comfortable, they know they're not symptomatic in the sense of outward, and that for they can get perhaps away with coming to work, but what are the unintended consequences of that, both from a health level for our other workers as well as our residents or patients in healthcare facility, and what are the impacts from a perspective of finances and cost. So if we look at this example, and this is clearly a conservative estimate, if we have one person who comes in sick, one simple spread example can in 9 days create 19 absences. And this again is a conservative number. Presenteeism increases the spread, and 50 to 90% of healthcare workers report they have worked or would work with experiencing symptoms of infection. And if we look at all different types of healthcare facilities, it can perhaps be about 35 to 97% of folks that are coming in to their workplace, recognizing they're sick or being misinformed of whether they're sick. Rick is going to share a study that was conducted during the SARS outbreak that really provides some illustrations to this picture. So here was some data that was captured, and this was with the case study that was conducted that Rick will get further into, and looking at the potential value of capturing that sick person at the door. So in this example where they identified an outlier, as you can see there, the red X there on the top, identifies where that individual, based on their own baseline temperature, had an outlier, recognizing that they were able to remove themselves from the workplace for a period of days and minimizing that transfer of infection. So this is a nice visual to validate and show how that one capture can lower that transfer of infection to others. How have we gotten surveillance so wrong? And I think what's important to understand here and looking at this slide, recognizing where we came up with 98.6 and where we came up with 100.4, which, as we all recognize, has been the temperature that has been determined to be the problem. So in our traditional surveillance, as we do now, if you are above that 100.4, then that will be flagged as someone who perhaps is contagious. However, what is happening and what we recognize is that there are a significant portion of the population that may be well below 100.4, however, is still contagious. And so they're not being captured, and they are what we would define as false negatives. So this chart in front of you, I think, is extremely eye-opening when you look. If you can see there, the numbers are quite small, but we start off sort of at the tail end on the left, and that's at 95.4, 95.5 temperature range. So that's a population's temperature. That's an individual, as far as 30,000 temperatures that were collected for this study. And then we see all the way on the other side of the chart where we're up to 99.1 and so on and so forth. And so we do not all have the same temperature, and that's important to recognize. Viruses like influenza, RSV, coronavirus follow a replication cycle. In the cycle, the viruses are released to infect new cells after hijacking the host cells to replicate. And our bodies initiate a fever response, which is a symptomatic reaction to an infection that has evolved over 600 years. And so to help fight this infection, the viral shedding, which is a key factor, intensifies and elevates the body's temperature. And so when we're talking about 100.4, these processes often occur before the onset of traditional fever symptoms, rendering fever screenings based on a threshold of 100.4 and questionnaires really ineffective in the very earliest stage of infection, when we also recognize is the highest opportunity for that transfer of infection. And so when we're looking and determining based on this protocol, based on this new technology, what are the implications of false positives and false negatives? And we recognize that false positives, if we identify someone who potentially is sick, but they're not, so that would be a false positive. What has been determined is through rapid testing, we can actually get those false positive numbers almost down to zero. So those false positives can be extremely minimized. When we're talking about false negatives, those folks that it identifies them as negative falsely, it is recognized that an asymptomatic spreader are detectable across the human temperature range, and reducing the likelihood of false negatives by 90%. So by using this new technology and setting a baseline for each individual, we are able to cut the amount of false negatives that enter our workplaces by 90%. And this process can be done in less than 10 seconds. And that's really the true value, is to capture those folks that perhaps would not have been captured before and create that opportunity for transmission. The heightened accuracy of the above normal temperature events based detection significantly reduces the rate of these false negatives, and that provides significant value. So with that, I'm going to pass it back to Dan, who will then pass it off to Rick to talk about how it all works.
Thanks so much, Sherry. Really, really interesting. And Rick, you're up to dig into more of the details.
Thank you very much, Dan. And Sherry, thank you for that clear explanation. obviously the thesis is that presenteeism is the reason for all this absenteeism, and I'm talking about obviously unscheduled absenteeism, which is the worst kind. I mean, it's unplanned for both ourselves, our work-life balance, our vacation, or maybe being unpaid if we're in contracting position. And most of what we're talking about here is just building the base to say, to validate what we've learned. And the way we learned it is by looking for a group that is separate from the other group. That would be the well people. So take an assumption that there are well people and there are, in this case, contagious, infected, at least infected people. And that with all the PCR testing that we have on certain classes of this data, for those people who were showing up for work, we can see how well, and that's a pun intended, we actually do. So with a particular, we could find this to about 30,000 temperatures as a group, and they were all going to take PCR tests if they appeared symptomatic, if they volunteered and said, you know, I'm feeling bad. This was in a senior residence. By and large, it's within a hospital, and the hospital obviously has immediate PCR results, which still take a few hours to get. So while we tried many different ways to figure out what this group was, obviously we're sitting in temperature, we worked through it, and we actually were able to transform the data of fixed temperatures. You know, people will say, well, I'm always a 97.2 or a 98.1. And from there, we were looking for what may be outliers. So it took AI, you know, the buzzword of the day, to actually learn what the person's normal temperature was. And these are all anonymized data. So where it is unique to an employee, we wouldn't know who they are and did not need to know any of the demographic of the person. We simply used weather, which is a very important factor we learned, as well as the person's normal. And so we could then estimate from the employee's fixed temperature how many people were clinically asymptomatic by temperature. And by the way, 90% of the infected people were asymptomatic. And this is sort of the thing that showed up in COVID. It showed up in H1N1 flu, which was some 13 years ago. This is the idea that they're silent spreaders. And it should strike fear in the minds of epidemiologists. Anyway, the overwhelming majority would go undetected, and that's what Sherry was talking about with false negatives. And this is why we call it the myth of 100.4, or even, and we see this in 99.5. So if you would just go to the slide before that, please. So here we see that we're in lockstep. We're going to show how we're in lockstep with both the amount of virus in the body and the amount that we spread. They are, and you could imagine, one and the same, but science requires that it be shown and certainly proven. So in the next slide, it shows the temperature gradient. And by the way, most of us are used to Fahrenheit, so 37 is a normal temperature of supposedly 98.6. And you can see that that's not necessarily true, even from that. So that shows what we had internally. So in the next slide, you'll see what we give out, what we spread. And you will see it's in lockstep with temperature. Temperature is not the later symptom, but there's a reason because of 100.4 that it is. So So most of all, this last graph shows the amount we find coming out of the body, mainly from our exhalation. And that's how it spreads. Much of it is through exhalation. And you can imagine we can fill up a room in one day, with our breath and the volume of that room, if it was 10 by 10 and 8 feet of ceiling. So we exhale a lot. So with this, we can fairly estimate that a person's spread is in fact lockstep. So I just wanted to point that out. And then next, we talk about increasing body temperature is the body's strongest defense against infection. This is not known to the layperson. To professionals, in particular infectious disease, nurses, the whole idea of a fever strikes fear in our heart because of scarlet fever and hemorrhagic fever. These things sound like something you want to get rid of. That is the fever. And as we all know, as in professionals in healthcare at a minimum, that in fact, this is the actual immune system doing the earliest work in ending this. And, we see this in reptiles where they have salmonella and they go out on a hot rock and they spend all the time it takes to get that infection to go down so that they can go do lizard things. And then, so anyway, the whole idea is behind this one gland, the hypothalamus. I won't go into it. You probably already know all about it. But it's right between your eyes and nose. And it's the thing that's job is to sense from the blood any of these proteins that show large number of destructive human cells, that show the other kinds of proteins that are unfamiliar to it. And for that, it sends messages to the skin to constrict, which makes it colder to the skin. And that's why we shiver when our head is about to explode in the heat. And so, and there are even thermometers that measure wrist temperature. And while that seems like a good idea, you will see that your extremity temperature goes down as your head oral temperature or your core temperature goes up. So in fact, they're going the opposite direction. So in the next slide, we are fever is mistakenly thought to be that terrible thing that I just talked about. So again, and I just want to reiterate, because I can't say it enough, that particularly to lay people, that elevated body temperature is the earliest and greatest defense. That gives us a 2 or 3 day time before the white blood cells are able to multiply, and they create, as you know, killer cells and antibodies, which are just proteins, to end this onslaught of the viral, if you will, invasion. So then the next slide is that from all this work that we've done, that I'm going to show you a little bit more about the validation and why and how real this is and how significant it is as well. More than 90% of sick employees are well under this 100.4 clinical fixed definition of fever. Now, we have clients who set it at 99.5, which we've seen the EEOC and some other guidelines, that do that. So what that enables them to do is catch more infectious people. And it's only about a double, which is taking you from 5% of all the infectious people coming in to maybe 10%. So we have 90%, in effect, false negatives coming down. But at the same time, at 99.5, we get a few false positives. And when they do such things as sending people home, you're going to have people who say, hey, I was well, and now you're sending me home. That's not fair. So our protocol, or the protocol that we're talking about, I don't want to take possession of that. The protocol we're talking about is to alleviate that. Those false positives. So what did this case study reveal? And so we go to the next slide. that with 6 months of data, that would be over fall and winter. And you can imagine those are the times, with the exception of the summer colds and things like that, which are real, that fall and winter are the times, particularly around New Year's. You have Thanksgiving where there's outbreaks, you have Christmas, and these are, materially serious ones, but you'll see on your absentee rolls that, it happens all year round. Anyway, out of 30,000 scans, of 600 healthcare workers, 150 senior residents, staff of those 600, all were PCR checked when they felt symptoms, as I mentioned before, and all were scanning upon entry. And the AI showed this tiny bump. And so in the next slide, and I'm going to ask you to wait for it as far as the tiny bump. What you see here is the spread on the left-hand side of all the people that our AI caught as potentially or likely contagious. And you will see at the 100.4 fever guidelines, and our data is a little bit more intense than this. This is an illustration we made, that there are about 2 handfuls of people that met those CDC fever guidelines out of 30,000 scans. So on the well side, on the right side, we see how we actually separated it with this, what we call the new wellness protocol AI. So in the next slide, I'll show you the bump. Okay, this is, familiar to us probably for me years ago in college. A histogram, and this isn't actually temperature. If it was temperature, you'd see the 97.7 right up on the big, tall part of it. But what it actually is the amount of deviation that people had. And we're only looking for deviation, obviously, when it comes to fever and the hypothalamus we mentioned. We're only looking for outliers that went high. And while it looks kind of normal, even when the outliers are 1.7 or so, there was a bump. And that bump has to be explained statistically. And lo and behold, we amplified that bump, and that's just something we do in Excel. In this retrospective, we actually see that there's another population here. And I can tell you, without that you probably can imagine right now, these are people who are infectious or at least infected. So that is the key to the discovery. So we went and we made a more idealized kind of look at it. And in this idealized look, as right there, you see the bulk of the population. And if you read the left-hand vertical, you'll see 10,000 and 8,000 and 6,000. When you add all the area under that curve, you're looking at about 30,000. And minus a few, which are all in the sick range. So if you look on the right side, we've amplified the bump, and you'll see in the right vertical axis, small numbers. There's 10, there's 20 at a peak. And these are the amount of outlier, numerically, how much of an outlier those people were. What's really interesting about this, and to me, it's a very exciting discovery, and we've been sitting on this for almost a year trying to get our analysis right and scientifically validated. And by the way, all the sick validation is done through the PCR testing and connecting. Not that all the people we say are sick had PCR tests that were positive, but in the healthy group, we found few to no PCR positives. And in this bump, we found a significant number of PCR positives. The number is actually quite low, though. You'll see on negative anyway, you'll see at positive predictive value of about 15%. Now, that's about 10 times greater than any random selection. So if we tested everybody or tested 1 out of every 100, we would see 1%. But we're at 15 times that. But the actual PCR test that we did was not of infection. It was just of COVID. And at that time, and it's just last year, it ended last year as spring came in 2023. In that 6-month period, um, we actually had flu, RSV, and this thing we're hearing more about that we've been studying for many years, but it's called ILI, influenza-like illness. So that's where, on the personal level, we go to the doctor and we say, what do we have? Well, you don't have COVID, you don't have RSV now they can test for, you don't have flu they can test for. So you have ILI, which is, what we don't know, but you seem to be feeling bad enough to get that category. So if we included a flu test and RSV test, there's no question that that number would go up in terms of its positive predictive value, because we're not looking for COVID. And frankly, admittedly, we can't find specifically COVID. We can only find infection. And that is just the nature of fever, elevated body temperature. So one of the things on the lower right-hand side came from, I think, the CDC. I was going through there and somebody had up on their board, "In God we trust, all others must bring data." And I also found it quoted by IBM on their website. So, we felt very compelled, and it took us an added year to get all this validation together. And this, by the way, is the moment where in the first hour we have ever presented this information. It is now being pre-published and presented to PLOS 1, hopefully for their peer review and acceptance. And I would be glad to provide to you at any time that study. It's about 35 pages and, intense with figures and details and good explanation, in my opinion. So in the next slide, we talk about what to do. I mean, here we are. That's great. You found all this infection. What are you going to do? Send people home or whatever? Well, we're going to get a 95% reduction in disease burden. It could be greater. It could be, and we've all seen the people who run their mask under their nose. So there's some enforcement, or at least some need to have employees comply, so that reduction is in fact N95 like, and so provided at the station when told, because we have a speedometer that shows how much of an outlier you are, and we also have validated where the beginning of that very likely contagious moment is, as you saw in the two histograms in our idealized one. And so the other thing that can be done besides just asking somebody to don an N95 mask is to provide remotely proctored self-tests at the front door. So all of this is simply validating the fact that once we see this kind of factor, that in fact you're contagious. And I've seen it in myself one time this year, about 2 weeks ago, and it read high for 2 days. And in fact, I didn't have COVID, but I had ILI, the doctor said. So anyway, in the next slide, you actually see what's going on. Now, this is from NIOSH, National Institute of Occupational Safety and Health, and they're always looking at the respiratory system and the ability to spread and the ability to protect the person. And so we're not going to go into the fact that masks actually help you avoid illness. That jury is out as to what those numbers are. We're only talking about contagious people. And that's been clearly shown in surgical masks and such. Not that you won't want or think your surgeon is sick, but if so, you have a basically exposed wound when you're having surgery, and you want to take every chance away from the possibility that you could get sick from a surgeon who would be, say, asymptomatic. So in the top, you'll see the sick person. If you go all the way out to that number 30 feet, 10 meters, you will see the droplet falls off after about 2 meters or 6 feet, and you'll see that airborne continues. These are two completely different particles. Droplet is a moist particle. It could be as small as 1 micron, but it's full of saline. That's what our bodies, that's what our bodily fluids are. They're about a little less than 1% salt water. And so what happens is that salt water starts to evaporate and that pickles the virus. So a droplet lasts a while. It becomes what we call fomite. Infection preventionists listening may be very familiar with that. But airborne is like a feather. It's extremely low density. And it comes out of us at 100 degrees, just rounding up. And it comes out at 100% humidity, assuming that you're hydrated, as we all should be. And that leaves it airborne in almost the head level and a little above, and it travels in what's called Brownian motion. I won't get too far into that. So the 95% reduction in disease burden comes from the fact that we mask these people that we've identified and validated could likely be infected and then likely be infectious and thereby contagious. So to the next slide, I just wanted to really point out, this is a pathological case, excuse the pun. This is SARS, and we probably remember SARS, we studied it maybe. In 2003, this odd thing called a coronavirus, very close cousin to MERS, to COVID-19. And one patient turned out to be at the very beginning. What's so interesting about this is that the people who spread and by the way, these, somehow in Hong Kong at the time, they didn't have HIPAA or GDPR, but these are named people. And so Ms. A.B. Was staff, and you'll see that all these people that spread, maybe 5 or 6 that you'll see there, all these people were staff. And that's not because staff is doing anything wrong. We're working, we're covering distances. We're there for 10-hour shifts. But anyway, then the other leaves of this tree are mostly guests. Now, this was, as I say, a pathological case because of the 150 that were sickened at this teaching hospital in Hong Kong, a large hospital, very prestigious. 50 people died of SARS. Most of these people readmitted as patients, and most of the people who were sickened were staff and guests, but most of the people that spread were the employees and staff. So I think that's compelling to the argument of what's actually going on. And then finally, to sort of give you a more contemporary thing. If you go to the next slide, please. So the New England Journal of Medicine, renowned journal, particularly for clinical, they actually printed, and they do from time to time, something a little more epidemiologic. And so this shows what happens in senior living. And this is a study of studies called a meta-study. And that study of studies showed that high test facilities, and these could be surveys, in particular temperature testing, that they had a high confidence reduction in the amount of infection and death in the residents by high test means employee testing. So I wanted to point that out. All of this information is available. I can send you links and whatever. I have a cell phone number down there. It's best to text me. And so we go to concluding what we show here. And with this new this new wellness protocol using this AI piece, I'm glad to explain and share. There's a reduction in the unscheduled absenteeism. And I won't go into the numbers, but you can imagine it's significant. And if you're a person in the facility, you are greatly benefited because you're probably going to wind up with an absence of maybe 1 or 2 per year. and to reduce that further is very significant personally. So approximately 1 in 100 employees will wind up walking around with N95s if that is the choice. And if they're presenting with a nominal amount of contagiousness, and these are all policies that you would make for your institution, and to keep in mind, even when you're servicing your patients at the bedside, that there is a extremely hard shell around privacy for employees. We don't know you, as far as the study requires no knowledge of employee demographic or name. The identity is obscured and in this protocol. So what you then lead to is a non-disruptive isolation method. So to go to lighten the air on the next slide, I just wanted to offer my contact information. This PowerPoint will be available. The study upon request, it's a very dense scientific validation. But please feel free to text me. You'll get a better response from me because I don't take, obviously, calls that I don't recognize. And that would be a pleasure. You see my email there. Please feel free to contact me. And you see our web address. I'm going to turn it back to Dan. Thank you for your time listening. These are very compelling things to me, and I hope you got the feeling that, at least to me, that these are significant things.
Rick, thank you so much. It's very, very interesting. A lot of questions. And you mentioned the presentation will be available at the TIPS website. So all the attendees will get an email. You can follow the TIPS website for a copy of the presentation. And then also we've recorded the presentation, so that'll be available for view on the TIPS website. First question, this is, I guess, probably for Rick, what types of workplaces have you found the most value with this new technology and protocol? I was thinking hospitals, but I didn't know. It sounds like some others. Yeah.
Well, in manufacturing, I have to go there because it's usually a dense, generally profitable, a profitable business venture. Yep. So we have a high density of people. You can imagine assembly lines. You can imagine QA people who are actually walking around. And so there is a significant expense to a unscheduled absence. These are very well organized teams. So we've seen that. Naturally, HAI, hospital-acquired infection, as I used to call it, nosocomial infection, that these are significant to the patients. And what we have seen in some of the modeling that we've done, and even intuitively, is that employees are spreading to employees. They're not necessarily spreading to patients, and patients are not necessarily spreading back. So HAI is still, the scariest thing to have. And then, of course, in senior residences, seniors are taking the hit on the majority of death and injury from these diseases.
Yeah, and if I could just add on that a little bit, is in knowing the senior living sector, and our employees, they're working on average 4.5 to 5 miles a day throughout those facilities. And so we unfortunately did identify during the pandemic that they really are the, quote, super spreaders per se in these long-term care facilities. And I think there are a significant population that needs to be protected, and I think a significant focus for this technology. I think there's also a value because there's times in senior living where they're all masking regardless. And so this could even be a value in the sense of recognizing those that are literally do need those protective measures and additional PPE, and those that don't. So I think senior living is definitely a prime sector for this technology.
And to kind of bird dog off that, like specifically, Rick, like if I'm just thinking as hospitals work, they're already taking temperatures, but how would they implement this protocol? Like, how would you envision, would it be would it be frequency that there'd be different numbers that they would use? Like, how would you, if they're already, obviously, going to a hospital, they take your temperature one time, but if I'm a hospital and I find this really interesting, what would they look to do, or would it be a multi-step process?
What we find, and this may be the engineer in me thinking, but what we find is the largest problem and spread of this is employees. And it's not employees to patients, as I say, it's employees to employees. So that's where it's all gathered. So when we come to work, I remember the days that I had lockers. I would come to a place that had my coffee, and that would probably be a good place to take temperatures, note them down, or whatever to make this determination. So we've had critical care places use these on guests, and obviously guests are a very scary thing in ICUs because it's an open area. And so they use that for guests, but we require to get this, this validation requires that we see the identity of that person without knowing the actual identity, and that we see at least 3 times before we get a pretty good look at what their normal temperature is.
Right.
So common areas, and not at doors, it's just common areas.
There was a question to Rick that said, you mentioned 99.5 as a temperature some surveillance programs are using. Are you aware of the science behind it?
It is the science is really Bayesian statistics. It will, it's a matter of what you want more. Do you want to possibly inconvenience people more, or do you want to catch more contagiousness? And so 100.4 assures you that you have a contagious person, or at least an infected person. 99.5 gives you a little more possibility of a false positive, but it gives you more true negatives. So it's more like a policy decision, a risk analysis that's required.
On the policy front, what do you see in the next couple of years in terms of any change in guidance? Because obviously hospitals are going to go off what the CDC recommends, and is that something you're actively engaged in, or once the data is published, further discussions?
Well, the CDC would be our best friend. They're public health. And there's some confusion, and that's where the 100.4 comes from, between clinical diagnosis, and we are by no means, a diagnostic, but there's that conflict. And so we have to pull that apart, and that takes, care about the wording of these kinds of things. Again, being non-diagnostic, but being a decision tool to identify what may be likely a contagious person, with the only problem being that they have to wear an N95 mask, and it only being 1 in 100. So I think the future, I would like to think that the future, however it's implemented, would be to use these formulations, which, as you can imagine, is about 100 microseconds of processing power to make these determinations. So we just need to identify the person uniquely. And that could be a barcode from a can of spinach, as long as they always present the same barcode of that can of spinach, but nobody else has that as their barcode. So it could be driver's license. We take, our unit takes RFID and things like that.
If I can jump in there too, as well, just looking at what we see coming down the pike as far as regulation. OSHA, obviously, with the pandemic, Occupational Safety and Health Administration was looking at mandating worker protection surrounding infections. There's an infectious disease program that was a proposed rule under OSHA for a number of years that never really went anywhere. Obviously, with the pandemic, there's been some vigor focused on perhaps bringing back that rule. So I think there is some onus on the workplace and on HR to make sure that our workers are being protected when they're in their workplace. And this could be a very essential component of that protection. So I think we'll have to see where OSHA comes down on that. There's obviously always a lot of contention when it comes to different types of requirements from OSHA, but that is definitely something OSHA's looking at. And I think this could be a key component of it.
Great. Rick, you were going to summarize kind of the learning objectives. I thought now would probably be a good time for that.
Okay, and thank you very much for the nurses who are attending for their continuing education. I hope this was helpful. We tried to explain and hopefully did, and even validated how presenteeism, that's coming to work sick into the workplace, and how that drives outbreaks. And that one person that you catch using these kinds of methods is about 5 people on average that will not be absent in, say, 3 to 5 days as that contagiousness incubates. So I hope that was clear. The myth of 98.6 is very simple, and Sherry showed that clearly, that we're just not a 98.6 Fahrenheit. And there, if you want to Google it and go into the history of it, you might find, Wonderkind or Wonderlic, I'm sorry. And that it really is a round number in centigrade. I think it's 36 or 37. And then 38 at 100.4, 38C is the 100.4. So these are sort of round numbers. They're used as rules of thumb. And, when you go to a clinic, these numbers are taken into account with a myriad of other things that experts, clinicians use to come to some kind of diagnosis. So the consequences when it comes to looking, number 3, when it comes to looking for contagiousness, is to miss many by using what the clinical diagnostic guideline of 100.4 is. And so the CDC would do well, and when you consider those consequences, to see if there's any way that they can make that a little bit more realistic. And we think that this will do it, although it's probably complicated to understand, but it's easily programmed into a handheld or whatever. And ultimately, the role of fever in the body's defense against infection is the single most thing, I hope I explained, the single most thing that we get wrong for ourselves, for our children, for our parents. When we see things like 98.6 and we say, oh, that's a low-grade fever. Well, if the person is at 97 degrees, typically on their normal, then they're really at 100.4 as compared to 98.6, if that was their number. And as we know, as we get older, we get colder. So I hope that so that was clear, and we'll just reinforce that in our minds. Hopefully we already know about this. So that was what we hoped we presented as our objective in learning.
Great. Well, I think we're wrapping up here. Sherry and Rick, thanks both of you for the presentation. Happy to moderate, and like I said, you'll be receiving information for those attendees on the presentation, and if you have friends that were not able to attend, they can view the recording from the TIPS website. That'll be listed probably early next week, and then look for some additional webinars in the future from TIPS. And everyone have a great day. Thanks again.
Thank you.
Thank you.